Hello everyone, it's our pleasure to have you today in our webinar that's held by Emirates Society of Ophthalmology and sponsored by Novartis. And this webinar is going to be about retinal emergencies, and I hope all of you will have a nice evening with our nice interactive presentation with all the variety of presenters. And I hope you are staying safe during this hard time of the year with COVID-19. So our first presenter is all the way from Canada, Dr. Ali Dirani. He's the clinical professor and director of clinical research in ophthalmology department, University of Laval and Quebec University in Quebec, Canada. And he will present about posterior segment trauma and intraocular foreign body. Dr. Ali, the floor is yours, and you can start your presentation, please.
Thank you, Dr. Mansouri, for this invitation. It's a great pleasure to present to the Society of Emirates, Ophthalmologic Society of Emirates. Today, my talk will be about posterior segment trauma and intraocular foreign body. So, I have no conflict of interest related to this presentation. In this presentation, I'm going to talk about closed globe injuries, including hyphema, lens and intraocular lens subluxation and dislocation, vitreous hemorrhage, COMMOTIO, retina, choroidal rupture, retinal detachment, and also I'm going to talk about open globe injuries. A special attention will be on the intraocular foreign bodies. So, as you all know, the eye trauma is very frequent, and about 1.6 million have blinding ocular injuries worldwide. In the USA, ocular injury are the second cause of visual impairment after cataract. And for sure, as you all know, cataract can be solved by a very simple surgery. On the other hand, eye injury cannot be repaired easily, as we will see in my presentation. Ocular injury are more frequent among subgroups of younger people, males and low education groups. So you have all heard about the ocular trauma classification. This article, which was published in 1996, is very interesting, and it has classified ocular trauma according to specific definitions. So during my presentation, I will adhere to these definitions, and when I talk about laceration, penetrating, perforating injury, I will define them as they were described in this article. So in the ocular trauma classification, visual outcome after ocular injury were dependent on mechanism and extent of injury, visual acuity at presentation, presence of relative afferent papillary defect, and zone of injury. Zone of injury are described as corneal, corneolimbal, or scleral. And it's very important to always measure the visual acuity of patients at presentation. It's an easy exam that can give us a lot of important information about the prognosis after the surgery. I will start with the closed globe injuries. Hyphema, I will not discuss hyphema since it's not part of our objectives. For lens and IOL subluxation and dislocation. Evaluation of cataract after blunt trauma is very important. Sometimes the cataract can start early after the trauma, sometimes it can start later on. We should always look for the presence of iridodonesis, iridodialysis, and the presence of vitreous in the anterior chamber. I had recently a case of patient who had traumatic cataract, and he also has associated iridodialysis and ciliary body cleft. So the patient has hypotony related to the ciliary body cleft, and if we have fixed on only the cataract, we couldn't have improved the patient. So it's important to have a good examination of the patient. The intervention will be urgent if we have papillary block glaucoma, if we have uveitis that is not respondent to drops, and if we have lens corneal touch. Otherwise, surgery is deferred. It's very important to plan our surgery before going to the OR. For example, we should examine the patient to see if there is a sulcus, and if there is sulcus, we can put the lens in the sulcus. Otherwise, we should plan our surgery, and we should ask for a specific lens to do specific techniques. For me, if I have a patient with sulcus, I prefer to put the lens in sulcus with optic capture. Otherwise, I use AKREOS sutured lens or Yemeni technique, and my preferred technique is AKREOS. As you will see in this video, this patient had a blunt trauma with dislocated lens. So we have done the surgery to remove the lens and then to suture the AKREOS. I'm showing the video very quickly. After a thorough vitrectomy and posterior hyaloid peeling, we remove the lens through Pacman technique, and then we insert the lens AKREOS and we suture it with 2 Gortes suture. As you can see, the lens is very well centered. It's very important if we have other injury like iris dialysis, they should be repaired during the same surgery. I do not do iris repair. I refer them for anterior segment surgeon if needed. And it's very important to always examine the retinal periphery to rule out retinal breaks or small detachments. I do not recommend to use scleral buckling prophylactically. I only use scleral buckling in case of presence of associated retinal detachment with PVR. Let's talk about vitreous hemorrhage. When vitreous hemorrhage is present, the outcome after trauma is worse, as it has been shown in many studies. And in a study published in Retina, visual acuity was less than 2200 in 50% of patients who presented with vitreous hemorrhage associated to blunt trauma. Other prognostic factors are traumatic cataract, high FEMA, older patient having young patient, and patient presenting with low visual acuity. If we have many factors, the vision will be worse after the surgery. COMMOTIO retina and avulsion of vitreous base and retinal tears, I will pass quickly. We should, as I said, we should examine the patient after a blunt trauma. I do not recommend laser for COMMOTIO retina unless there is a tear associated with COMMOTIO retina. Sometimes the epiretinal membrane or pucker can develop later after the COMMOTIO retina. Unfortunately, it's very difficult to treat this patient, and visual acuity will be very limited. I don't recommend to use prednisolone in these cases, and there is no study that support the use of prednisolone in these studies. So usually I observe the patient. If there is macular scar, the vision will be for sure very, very low. In case of presence of retinal breaks, we should do laser. If we have retinal dialysis, it depends on the location of the retinal dialysis, but usually we do a scleral buckling in the presence of retinal dialysis for patient. Usually young patients have retinal dialysis because older patients will develop retinal detachment. In older patients, the vitreous will be detached and they will not have retinal dialysis. Usually retinal dialysis develop in patients younger than 40 years old, and we can do in these cases scleral buckling, and results are pretty good. This is a case of a patient who had blunt trauma. As we can see, he had scleral rupture, but it did not affect the macula nor the optic nerve. We have done scleral buckling for this patient with vitrectomy. After the surgery, the patient developed fibrous tissue on the surface of the retina, but it did not affect the macula, so visual acuity was acceptable in this case. In case of choroidal ruptures affecting the posterior pole, the vision will be very poor, as we can see in this case, and those patients can develop choroidal neovascular membrane. For the retinal detachment and macular hole, surgery should be done to repair the detachment and to close the hole. Usually, the vitrectomy is the first approach for patients with the retinal detachment after trauma. Unless there is a lot of PVR, we can combine vitrectomy with scleral buckle. I usually do endolaser 360 for all patients after trauma. If the patient has a giant retinal tear in the eye associated with trauma, we can consider doing endo laser. We can consider doing laser, prophylactic laser for the other eye, 360, as some studies have shown that we can decrease the risk of retinal detachment in the other eye. Usually, patient who develop giant retinal tear has certain predisposition to have a giant retinal tear in the other eye later on. For the traumatic macular hole, usually I wait about 4 weeks before proceeding to surgery, because about 40% of patients will experience a spontaneous closure of their macular hole. Unfortunately, visual results are not very good with traumatic macular hole, as some patients can develop macular atrophy. We can have extreme holes with big dimensions, but sometimes the hole is small and the vision can improve after surgery. This is a case where a surgery was done and the hole was closed after surgery. For the open globe injury, I'm going to speak about different items. It's very important to evaluate the patient preoperatively, and as I said, visual acuity is very important to predict the visual outcomes after the surgery. On the other hand, we should always keep in mind that perforating globe injury can be associated with intraocular foreign body, and if we have any suspicion, imaging should be done to rule out the presence of intraocular foreign body. And it's very important to well document the patient file, since a lot of lawsuits we can be suited because of a patient who had trauma, since they are a young patient and they want to have insurance and they want to have coverage because they will not be able to continue their regular work. So sometimes patient with penetrating globe injury or perforating globe injury can have light perception vision. This is a prognostic factor, but we should always try surgery, since some patients can have visual acuity after surgery. Some signs of occult scleral rupture are diffuse chemosis or diffuse subconjunctival hemorrhage, low intraocular pressure or asymmetric intraocular pressure, shallow anterior chamber. On the CT scan, we can see a flat tire sign, as we can see here. This is a sign of penetrating or perforating injury. B-scan can be interesting, but sometimes we cannot see the intraocular foreign body. It will depend on the nature of the foreign body. For example, in this B-scan, we can see it, but usually we cannot see it. We should ask for X-rays, lateral and in-face X-rays, and if we have the possibility, CT scan is the best. We should always keep in mind that patient with penetrating with the globe rupture can have associated endophthalmitis at presentation. If we have endophthalmitis, we should address this problem and treat with antibiotics. Repair of laceration, it should be done as early as possible, within 24 hours, to avoid the risk of endophthalmitis. The aim of the first surgery is to restore the structural integrity of the globe and to evaluate the ocular damage. We do not recommend to do prophylactic scleral buckling for patients with open globe injuries. As I said before, if we have a retinal detachment, scleral buckling can be used, but not prophylactically. Same thing for the presence of intraocular body. If we have a suspicion of intraocular body, the surgery should be done as early as possible. And we usually do it within 24 hours of injury. We should differentiate between inflammation and endophthalmitis. If we have a suspicion of endophthalmitis, we can inject antibiotics during the surgery. The aim of removing intraocular foreign body is to avoid inflammation, and sometimes some intraocular foreign body can have copper or iron and can cause retinal toxicity or macular toxicity because of the iron or of the copper. Removing the foreign body will help to restore vision. We usually do a thorough vitrectomy when we want to remove the foreign body. It's very important to peel the posterior hyaloid membrane to avoid PVR after the surgery. As we know, 65% of patients with intraocular foreign body can develop PVR after surgery, and one of the major cause of PVR or source of the PVR is the presence of remnant of posterior hyaloid. So I recommend using dye during the vitrectomy to see all the vitreous. I usually do 360 laser during the surgery when I remove intraocular foreign body. Sometimes we can use perfluorocarbon to protect the macula, so if the foreign body falls from our forceps, it will not fall on the macula. We can enlarge the scleral incision to remove the foreign body, as we can remove it in a different way, as I will show you later on in this presentation. Sometimes we can have inert non-magnetic foreign body in the eye. These foreign body will cause less inflammation and can be tolerated for a longer period. We recommend the use of prophylactic antibiotherapy orally for patients with intraocular foreign body for at least 7 days. Literature is divided on this subject, but I think that prophylactic antibiotics is indicated in this case. Overall, patients with intraocular foreign body can have good visual outcome, and half of them can achieve visual acuity equal or above 20/50. Worse outcome will depend on the extent of intraocular injuries. For example, if we have uveal or ciliary body injuries, the vision will be less, the prognosis will be worse. If we have a big intraocular foreign body, the prognosis will be worse. And for some intraocular foreign body, like BB palate, the vision will be worse, as it was shown by some studies. Here I show you a patient who has intraocular foreign body. A surgery was done for this patient. This patient had an associated retinal detachment inferiorly. A scleral buckle was done, and laser 360 was done. The foreign body was incarcerated in the sclera, and it was removed by a scleral incision directly through the sclera, and not without going within the eye, but a thorough vitrectomy was done during the surgery. As you can see in this image, the retina is pretty good and the visual acuity is good. I will prefer technique to remove the surgery, to remove the intraocular foreign bodies, to remove it through corneal incision. This can help us to avoid doing sclerotomy, large sclerotomy, and we usually do this combined with phaco. As I will show you, usually you will start with a complete vitrectomy. Then we do posterior hyaloid peeling. We do shaving 360. After that, we do cataract. Sometimes we can start with cataract if we want, but usually we start with vitrectomy and to examine the retina and to see the extent of injuries. After that, we do cataract surgery. Usually patients are young and it's a kind of clear lens extraction. Then we remove the intraocular foreign body. We do posterior capsulotomy and we pass the intraocular foreign body through the capsulotomy. We put it on the iris and then we remove the foreign body through the corneal incision. This technique is very interesting when we have big intraocular foreign body. We don't have to enlarge the sclerotomy. And in case you prefer to remove it through the sclera, pay attention not to do your sclerotomy on meridians 3 or 9, because you will end up with a corneal hyposensitivity and with corneal keratopathy. And we have published our series on cases who had combined phaco-vitrectomy for intraocular foreign body. We had 13 patients who had this technique, and only 3 patients out of the 14 has a redetachment related to PVR. Usually in the literature, the PVR develop in more than 50% of patients. As you can see, patients with intraocular foreign body can have excellent vision. As you can see with patients, we have many patients with 20/20 and 20/25 vision. The good thing about doing the cataract at the same time, the patient will not develop cataract later on, and he can go quickly to work, since a big part of the patients are of working group age. I have done recently a review of cases of intraocular foreign body in my center. From 2009 till 2018, we have a total of 54 intraocular foreign body. And foreign body was mainly of metallic nature, about 90%, but sometimes we have vegetables, sometimes we have firework particles. Mean age of patient was 42 years old, and 90% were male. And the factors that were associated with the bad visual acuity were the presence of low visual acuity at presentation, the presence of associated perforation, the size of intraocular foreign body, the presence of vitreous hemorrhage, the presence of associated retinal detachment, the presence of hyphema, the presence of iris trauma as defined by iris dialysis or iris atrophy, and the need for a second surgery. This work will be submitted soon for publication. On the other hand, sometimes we can have tolerated intraocular foreign body. This is a case of a patient who had intraocular foreign body related to lead shotgun. The intraocular foreign body was in the eye for 9 years, and as you will see, the patient still has good visual acuity. She can see 20/25, and we can see periphery that the foreign body is causing some traction. This patient we did not decide not to do the surgery. For some reason, the patient has refused to have the surgery, and we have seen the patient later on. The foreign body was still here. The traction is only in the periphery. It's very important in case you decide not to do surgery, the patient should be followed yearly, and ERG should be considered in this case, as sometimes we can have a macular toxicity related to copper or iron that can be detected only by ERG. As we said before, perforating injuries are associated with poorer prognosis, and sometimes we need to delay surgery for about 7 days so the sclera can heal and we can do the vitrectomy. Otherwise, the eye will be soft and the vitrectomy will be very difficult. So it's a real balance between doing the vitrectomy early or late. If we do it early, the eye will be very soft and the surgery will not be easy. If we wait for a couple of days, the sclera will heal and we can do the surgery. But on the other hand, the PVR can start to develop early and we can have PVR. In general, PVR develop about two months after surgery, but in cases associated with the intraocular foreign body, the PVR develop very quickly. So we can experience a very, very advanced PVR during the surgery. Sometimes we can have retinal traction. The retina can be dragged. So we recommend to do a thorough vitrectomy and to avoid doing retinectomy, and to try to doing retinectomy in those cases. We should have the retina flat even if we have to do retinectomy. Here is a case of a patient who had a perforating injury. Here we can see the cornea was repaired. We can see the retina with dragged retina. We can see a lot of plia in the retina. So the management of perforating injury depends on each case, and sometimes we may need to do a chorioretinectomy to remove all the traction on the retina. If we do chorioretinectomy or only retinectomy, we usually use silicone oil as tamponade. The presence of vitreous hemorrhage and retinal detachment should be also addressed if we have open globe injury. The surgery is more complicated, and the use of scleral buckle can be indicated, especially if we have PVR at presentation. Sometimes we can have less associated laceration of ciliary body. When we have associated laceration of ciliary body, one of the problems after the surgery is hypotony. So in this case, we recommend to keep silicone oil in the eye on the long term to avoid hypotony. As I said before, patient with non-light perception should be also operated, since some patient can regain some visual acuity after surgery. For sometimes the trauma can be associated with hemorrhagic choroidal detachment. The surgery should be postponed for about 2 weeks in order to wait for the liquefaction of blood. We usually drain the choroidal detachment through a scleral incision or through a trocar. We can use unvalved trocar that we can put 7 mm or 8 mm posterior to the limbus, and the blood will drain spontaneously. So sometimes we have cataract associated with the trauma and with the retinal detachment. We should always consider doing phaco during the same surgery. Here in Canada, we are lucky since retina surgeon, we continue to do phaco surgery, and usually we do combined surgery for these cases. As I said, scleral buckle is optional, but it can be considered, especially in cases with PVR. Endophthalmitis should be always in our mind when we see patients with open globe injury, because it's a frequent complication, and it can occur in up to 15% of cases of patients with penetrating injuries. Sometimes it is difficult to diagnose endophthalmitis since some patients can have inflammation, so we should always have a high index of suspicion for endophthalmitis, and in case of doubt, it's better to treat the patient with intravitreal antibiotics and oral antibiotics to avoid further complication. In case of endophthalmitis, the causative organisms are different from endophthalmitis post-cataract surgery or post-injection. Usually we have Bacillus cereus and the gram-negative bacteria in those cases. It's very important to remove all intraocular foreign body during the surgery to avoid endophthalmitis and to decrease the risk of endophthalmitis. We usually use the same antibiotics that we use usually, vancomycin and ceftazidime, for the treatment of endophthalmitis associated with penetrating globe injuries. So we should always remember that sometimes we have late complication related to penetrating injury. The late complication can be cataract. Cataract can be related to the trauma or to the surgery. Sometimes we can have fibrotic membrane. Sometimes we can have papillary membrane. We can have macular pucker and retinal detachment. Please pay attention to the pressure of patient, because many patients will end with low pressure related to ciliary body detachment. Those patients may benefit from endoscopy with peeling of membrane on the ciliary body, and we can have good results for these patients. One complication that we should keep in our mind is sympathetic ophthalmia. It's usually a late presentation, but sometimes it can present early. We should always think about sympathetic ophthalmia in any patient who had a penetrating globe injury. I show this case. This is a patient who had a trauma in his right eye. He has developed sympathetic ophthalmia in his left eye. The visual acuity in his left eye was very poor after the trauma. So fortunately, this patient was treated adequately and the vision improved after the treatment. The patient had cortisone and sometimes we can inject the patient with triamcinolone to improve the visual acuity in those patients. So more important than the diagnosis of the patient with trauma is the prevention of trauma, and more important than our surgery is the prevention of trauma. So we have the American Academy recommend that people at risk should have protective glasses all the time. It's a mandatory requirement for patients who are monophthalmic, or for the patient who have visual acuity less than 20/40 in the contralateral eye. Some type of sport can be associated with the higher risk of eye trauma, so a protection is mandatory in this type of sport. Here you can see a hockey player. The hockey is our national sport here in Canada, and the LNH, which is the National Hockey League, has required all players to have a protection for their eyes during the surgery. And as I told you before, I don't remember if I told you, but many injuries in Canada are related to hockey, since it's the national sport here in Canada. Since this requirement was put, the number of professional players who had eye trauma has decreased significantly. And let's remember, all as ophthalmologists, sometimes we can be a source of trauma for the eye, especially when we do retrobulbar. Retina specialists usually do retrobulbar for all their patients, so we should always remember that we can be the source of trauma. And perforation during the retrobulbar anesthesia can occur in 1 to 3, can occur in less than 1%, and we should have a high index of suspicion when we do the retrobulbar. Sometimes signs can be very subtle. Sometimes we can have only a floater. The patient can describe floater. The patient can say that he has unusual pain. Sometimes we can have corneal edema, especially if we inject within the vitreous. As you can see in this B scan, the needle is very, very close to the globe, and it's very easy to do a scleral perforation. So pay attention to this and have a high index of suspicion. The peribulbar injection also can be associated with perforation. The safer technique is to do subretinal injection of anesthetics, but the anesthesia will not be as good as retrobulbar. Thank you for your presence, and thank you for allowing me to present. Here is a photo of my lovely city. I would like to invite all of you after the COVID-19 pandemic to visit Quebec. It's a very nice city. Thank you.
Thank you, Ali, for the nice presentation. Just I would like to remember the attendees to post their question in the Q&A option in the platform. So thank you, Ali, for this presentation. I know it's very hard to summarize all of the ocular and retinal injuries in just 15-minute presentation. So I have plenty of questions, and I will give some time. I will give you my question until the other panelists prepare their questions. So, Ali, did you notice any difference between seasons about ocular trauma? Because I have done my fellowship in Canada, and I know there was some season where we have a higher number of trauma, right?
Yeah, exactly. Because here they do a lot of skiing and hockey. So during winter we have high rate of ocular trauma because of the pack of hockey. And on the other hand, during the spring, when they start taking care of their garden, we can have a lot of trauma related to the work in the garden. These are the two main seasons for intraocular trauma or trauma.
Yeah, and you said you recommend giving oral or IV antibiotic for those patients. Do you have a specific regimen about what kind of antibiotic you use for intraocular?
Usually we do 4th generation fluoroquinolones, like Avelox.
As an oral medication, right?
Yeah, exactly, yeah. It has a good ocular penetration. It can enter through the vitreous. It has 95% ocular penetration. It can be a very good option.
And thank you for presenting this very elegant, nice technique to remove intraocular foreign body. But I was wondering about big intraocular foreign body. In case you won't be able to hold them with our regular forceps, right?
Yeah.
Would you recommend doing sclerotomy instead of shake hand technique?
In case you want to do sclerotomy, you should avoid, as I said, 3 and 9 o'clock. I have seen this mistake done by some colleagues, and the patient will finish with very, very severe keratopathy. Sometimes if it's a very big foreign body, we can do a scleral tunnel, and we can remove the foreign body through the scleral tunnel, sclerocorneal tunnel, as we used to do during the extracapsular extraction. before, we can do a sclerocorneal tunnel and we can remove it. The advantage of doing a sclerocorneal tunnel, it will be self-sealing and we will not have a lot of hypotony during the surgery.
Exactly.
And if we have
and
a retinal detachment, it's easier to handle
Yeah.
if the foreign body was removed through the cornea or through corneoscleral tunnel.
You are right. The other last question is about, usually those patients, they are young patients, and sometimes it will be difficult to induce posterior hyaloidal detachment, right? Do you have any
Yes.
special technique or any special recommendation for those cases?
Yeah, usually I use dye. I use Kenalog or triamcinolone in these patients so I can see the posterior hyaloid easily. For sure, using 23 gauge will help to peel the hyaloid since the opening of the cutter will be bigger, but it usually works. Sometimes we may need to peel it with a forceps and with a 25 gauge knife. We can introduce a 25 gauge knife and we can peel it like we peel a retinal membrane. This can help. But in those cases, I recommend to magnify and to use contact lens, to use corneal contact lens to see in 3 dimensions. Sometimes it's very difficult and sometimes we cannot peel it after many attempts. In those cases, I recommend to use scleral buckle, prophylactic scleral buckle.
Exactly. Thank you. Those are my questions. Now I will open the floor for the speakers to ask Dr. Ali Dirani if you have any questions, please.
Okay, thank you, Dr. Ali, for your excellent presentation, comprehensive one. It's very difficult, as Noura mentioned, that you summarize all this kind of stuff in one presentation. I have just 2 questions. The first one you mentioned that you can use scleral buckling with open globe injuries. That's what I understand from the talk, but if you have a case with big scleral rupture or scleral wound, do you still you can
no,
still
I
do
totally,
that? Because
I totally agree with you. If it's a very extended, I do not recommend. I recommend to close and to do a regular vitrectomy with silicone oil.
Yeah, with silicone oil.
But if there is a small scleral penetration, we can use scleral buckle.
Okay. One more thing also regarding
usually I use a small band in case I want to do a scleral buckle associated. I use a small band.
There is also, let me ask you this, because also one of the, it's in the same area, one of the question came from the audience. It's matching with what we are talking about. In the case of traumatic dialysis, what type of buckle do you prefer? Circumferential or which type of band you are using?
I will not say I'm a lazy surgeon, but I usually do circumferential buckle for all patients. And I don't have 20 years of experience, but I have some years of experience, and I have no case that I couldn't fix by a circumferential scleral buckle. Usually I use 41 band for all my patients, and it works well. I use it for combined phaco-vitrectomy or for simple buckle, and usually it works well. Sometimes I have to tighten it more for patients who have a posterior. Sometimes I should put it very posterior, but usually it works well with posterior. The main disadvantage of circumferential is the induced myopia because of the buckle.
Sure. Yes.
Usually patients accept myopia once they have a serious problem. Or we can address them to refractive surgeon. They can do refractive surgery. It can work well also for them.
Okay. Yeah, thank you. Regarding your published study, I've noticed that you use 1 case silicone oil and the rest was divided between air and SFC3F8 or F6. What make you decide which one to use? What you use air and...
Yeah, if there is no tear or no retinal detachment, we usually put air in the vitreous. If there is a tear, we can put SF6. If we have a beginning impending PVR, we have, for this specific patient, he had PVR. That's why we have put silicone oil.
And during the follow-up, those patients who you inject with air, go ahead,
Yeah, usually it's in the second surgery that we have put silicone oil for the patient, not during the first surgery.
Okay. And for your technique, you mentioned that sometimes you start with vitrectomy first and then phaco, and sometimes you start with phaco and then vitrectomy. My question, I think, I want to comment from your side. I think if you do phaco first, still the globe is normotensive, and if you do vitrectomy, you have to make the infusion on, and it might push the capsule, so it makes your cataract more difficult compared if you start with it. So any rationale for that, or it's go both ways?
Usually I do, as you said, usually I do phaco before vitrectomy, but I presented vitrectomy before phaco, so I can introduce my technique elegantly.
Okay, so the last one, sorry, because since you have good experience with foreign body, what is the best technique to remove retained ciliary body foreign body, metallic ciliary body foreign body? I know sometimes it's rare, but sometimes we see it. It's metallic foreign body. It's back inside the ciliary body itself.
I had recently a case. I couldn't see the foreign body, so I had to remove the cataract after I have done vitrectomy, so I can do a depression, a scleral depression. Sometimes if you have endoscopy, it can be a good tool that can help you to go and look for the foreign body.
What about trapdoor technique? Do you?
I don't. I have seen it in many videos, but I don't know how to do it.
So you go from inside, either endoscopy or because sometimes it's impacted to posterior. So even with sedation, you cannot see it, and you have to dig many times to see it. But with endoscopy, I think it will make your job more easy.
Yeah, I have the opportunity to be trained using endoscopy, and we have the luxury of having the endoscope in my department, so we can use it.
Yeah, thank you so much. Thank you.
Okay, my pleasure. Thank you.
Any question from your side, Dr. Adel?
Yes, thank you, Dr. Ali. Very elaborative talk. I really enjoyed it. I do want to ask you about dealing with the site of the impact of the foreign body. What do you usually do? I've seen that you have an impact of the foreign body there. What's your problem?
Yeah, I have included one slide, then I remove it after all because I had too many slides, but it's a very interesting question. It's a very important question. So usually it depends. If the impact is very peripheral, usually I do a very, very shallow laser on the impact. I do PRP separated laser scars on the impact of the foreign body. If it's posterior, usually I don't do laser if it's posterior. If it's posterior, usually I do peeling of ILM to avoid having a retinal membrane and PVR on the macula. And if it's peripheral, there has been some articles that have described the use of mitomycin for the treatment of the peripheral laser impact. They said that it can decrease the rate of PVR, but it's a small study. But it's a usable technique, but we should do a big scleral incision to introduce a sponge with mitomycin and keep it for 20 seconds or 11 seconds and then remove it. On the other hand, we had some surgeons use intravitreal methotrexate to avoid the development of PVR. It's a it's a long protocol. The patient should receive injection for up to 3 months. All those are experimental. We have no proof that one technique is better than the other. Usually I'm conservative. I do ILM peeling if it's posterior, and I do laser if it's peripheral. I don't do ILM peeling in all cases because I try to be the less traumatic possible. But in case the impact is close to the macula, I do ILM peeling. And as I said, I always prefer to do separated laser scars to avoid the traction of the retina. So if there is some traction, they will not be confluent.
Thank you.
Thank you.
So, Dr. Ali, I have just a few questions to answer them. They are from the audience, and I have 2 questions about retinal toxicity. So one question, would you consider surgery in case of mentioned return intraocular foreign body if toxicity developed, and how would you manage it?
Yeah, If the toxicity develops, the toxicity can be very advanced that the patient can lose vision. But if it's a mild toxicity with only ERG manifestation, I don't recommend surgery. But if we have a decrease in vision because the macula had some atrophic change, yes, we can recommend surgery. Usually the foreign body is old and we have a lot of scars, so retinectomy is needed in those cases around the foreign body, and we usually put silicone oil.
And there is one question as well, that they noticed rapid progression of retinal toxicity after removal of corneal foreign body.
Retinal toxicity, I cannot.
I
think maybe there is.
Can ocular toxicity still develop even after you remove the metallic foreign body or not? That's a question.
Yeah,
corneal foreign body. I don't.
No,
corneal. Corneal. Sorry, I didn't mention.
Usually with corneal foreign body, we don't have retinal toxicity because the iron or the copper should be within the eye for a long period, so the toxicity can develop.
But I believe,
and you recommend.
Sorry. Now I just want to comment, if the siderosis, for example, starts, it will be not stop, but that's why you need to remove it before the process starts.
Exactly.
Exactly.
That's why you cannot retain it. So that's the most important point.
Exactly. The other thing, would you recommend tab and inject for post-traumatic endophthalmitis instead of doing vitrectomy?
It depends on the visual acuity of the patient and the extent of the scleral laceration. If there is only endophthalmitis with a small scleral laceration that was repaired by a comprehensive ophthalmologist, we can do tap and inject, or we can do a vitrectomy, a localized vitrectomy to remove vitreous in the OR during at the same time of the surgery, and we can inject.
Exactly. Thank you so much, Dr. Ali, for.
Thank you. It was my pleasure. Thank you.
For your time and your comprehensive presentation, and we enjoyed your presence in our webinar.
I'm really sorry for not being able to attend my colleague presentation. I would be more than happy to attend, but unfortunately I have patients, and now it's 2 o'clock in the afternoon, and I'm in the middle of my clinic. That's why I'm really sorry. Thank you for your
understanding. No, not at all. Thank you, Dr. Ali. Thank you so much, and have a nice day and wonderful clinic there.
You too. Thank you.
So now our next speaker is Dr. Adel, and he's from Saudi Arabia, and he will present for us a very interesting case about as well some sort of ocular trauma. And for those who doesn't know Dr. Adel, he is a retina consultant, and so he is a member of Vitreoretinal Division, Associate Director of Outreach and Eligibility Department, King Khalid Eye Specialist Hospital, and Clinical Assistant Professor, and Ophthalmology Service Champion, Ministry of Health, Saudi Arabia. Now the floor is yours, Dr. Adel, and I would like to remind all the attendees to post their question and answer session, and as well as a final comment. Unfortunately, Dr. Raymond Ayezi, he won't be able to join us. That's why we changed a little bit the agenda, because he has an emergency retinal surgery to do due to the time difference. Now it's daytime in their side. So hopefully we'll be able to have him in another webinar during this time of the year. Thank you. The floor is yours, Dr. Adel.
Thank you very much, Dr. Noura, for this kind invitation. And I want to take you all to an area of imagination. I want you all to imagine what would be the worst case that you face as an ophthalmologist. And I'm going to take you through my version of this. So this was a 68 years old lady who had a sudden sharp pain during anesthesia prior to her cataract surgery. She noticed that her vision started to drop immediately, and she presented to our hospital within hours with a vision of hand motion. Her pre-op vision at this eye was 20/50 or pre-procedure, and the other eye was actually light perception. So this was her good eye. When we saw her, her IOP at the time was 10. She had a formed globe and a cataractous lens with no view to the posterior pole due to the vitreous hemorrhage she developed. So on this scan, I'm just going to go through this. She had vitreous hemorrhage, and she had hemorrhagic choroidal detachment with a retinal detachment, inferior retinal detachment. It's important to note that her axial length was around 26 millimeter. So, given this situation, it would be a very difficult decision to decide whether you proceed to do something in this eye or observe something that would push you to go and operate on this eye that she has a retinal detachment, and something that would make you wait is that you have a high suspicion that this patient had a perforated globe because of the injection. So we were giving her this chance to start resolve her suprachoroidal hemorrhage that she developed, and within a few days of serial B scans, we decided to go ahead and interfere. So we started by doing her cataract surgery, which was an uneventful cataract. And then as soon as we started the vitrectomy, we started seeing a very dense vitreous hemorrhage anteriorly. After removing this vitreous hemorrhage, we started to see things behind. And lo and behold, we're seeing this large subretinal dark mass of blood that has developed under her retina. So we continued doing her vitrectomy, and then we tried to peel the residual high load, examined the periphery looking for any obvious break, and we did not find any. So with this situation, in this patient who's a single-eyed patient and has this kind of subretinal blood with no obvious break here, what would be the best solution? Managing submacular hemorrhage is a challenging task. There are many algorithms that describe how you deal with this situation. I've chosen one here, and maybe I chose it because it says that there's the need of an expert vitreoretinal surgeon, and I believe I am one. I'm just joking. So looking at this in terms of age and in terms of the presence of comorbidities is very important. This is a patient who had no comorbidities in this eye other than her being a myope. We decided to perform a vitrectomy with a subretinal TPA injection and gas tamponade. This decision was made intraoperatively. It's important to know that injecting TPA is not a procedure without its own risks. There are reported local risks if you give the injection within 72 hours of bleeding within the subretinal space. And the toxicity has been reported with doses that are more than 50 micron in 0.1 ml. And there also has been reports of systemic complications from an ocular injection of TPA. So we carried on, and we went and injected the subretinal TPA. And as you can see here, although the video is not very clear, but you can see that there is this large blip that's forming, and it's encapsulating all of the subretinal blood here, or incorporating it. And then we went to air and then injected short-acting gas in this case. So back to this subretinal blood. Okay. In the post-op period, the patient appeared to improve her vision to counting finger in 2 weeks and then to 2200. And on 1 year, she had the vision of 20/70. And this is the OCT, which shows recovered outer retinal segments in her vertical and in horizontal, which is important. So, inadvertent globe perforation is one complication, and as Dr. Ali mentioned, is one of the things that we may cause, a trauma that we might cause as an ophthalmologist. And predisposing factors for this condition include posterior cephaloma, uncooperative patient, deep-seated globe, patients who have high axial length and had previous extraocular surgery, and an injection that's done by a non-ophthalmologist, which was the case here. Damage to the retina or to the photoreceptor can happen within 24 hours. So waiting and not interfering may end up with a very poor vision. The report has been that its mean would be around 20/1600. So, subretinal injection. It could be a fancy procedure that you could do, and it looks maybe cool in the operation, but we need to know that this procedure is done with limited information to the surgeon who's giving the injection. Sometimes you depend on your feeling while injecting. You only have 1 or 2 dimensions in looking to the image, and you actually need 3 dimensions. So that's why this procedure carries its own risks. And this is something that we should be very careful approaching in the near future because of the start of the use of robotic surgeries, and especially in the case of gene therapy where it's been deployed most. This technique I want to describe is one that's been there in the literature and I've been using in some of the cases. And it's by using the fluorescein dye mixed with the TPA. And this is done basically to allow for improved visualization of the blip. You can also ensure that there is homogeneous formation of or distribution of the TPA under the retinal subretinal space. It also helps you to see what is your entry site when you enter the first time because of the reflux that happens. Another thing that can be helpful is that when you go in the beginning and then you start to see this reflux from the beginning, sometimes it's because there is high resistance there and maybe you should choose another location. One other method that's very useful and I think will be gaining traction in the near future is using the microscope integrated OCT. This is a procedure that's been advocated a lot in the era of gene therapy because of its preciseness, let's say, and it's very helpful in early detection of this subretinal blip formation. Keep in mind that these procedures are done on eyes that have atrophic retinas, and there is a very high risk of developing a macular hole, full thickness macular hole. It also helps you understand where you're actually and which space are you moving. So if you're in the suprachoroidal space, you might retract a little bit. It also confirms that you've completed your foveal detachment, if that was your aim, and can help you looking into the OCT and seeing how the foveal depression is now moving and becoming as a dome-shaped appearance, because at this stage you know that you've already reached the full capacity that you can reach in this subretinal space. You can also use, which is a very useful tool, if you have if you're worried from developing a full thickness macular hole, you could use a subretinal, you could use a perfluorocarbon bubble that will support the top of potentially the macular hole that you're going to form if you don't. And you can also measure accurately the amount that you've injected in the subretinal space. And this is very valuable if you're dealing with a very expensive drug like those that are used in gene therapy. I'm going to show you here one case that I've used, and this is for another indication. This is a patient who had persistent subretinal fluid after an RD repair. And you can see I'm using here the 3D system from Ingenuity, the blip formation, and on the top right there you can see the OCT showing how the blip is forming. I'm at this stage have not reached the fovea, which was my intention, and I can tell for sure looking at my OCT that this is the situation, and then I can go and look through the OCT and find my first retinotomy and go through it. And now this is one technique I tend to use if I'm worried about causing any macular hole by over-injecting. I go to air and very progressively and slowly under low pressure do my fluid-air exchange and causing the increase in detachment of the macula till I reach the desired location. And this is what we've done in this case. Now that we've reached the fovea, this was the conclusion of that procedure. So, in conclusion, I think that the best way, as Dr. Ali mentioned earlier, to prevent a globe perforation is doing it yourself. I mean that you have to keep this in mind and try to prevent having this complication to happen to begin with. And it's important to know that managing subretinal fluid can be challenging, but prompt intervention and the utilization of helpful techniques and machine can make this a very fruitful procedure. And keep in mind that if you don't use the best technique in this, you might end up being replaced by the robots that are coming to take our jobs. Thank you very much for your time.
Thank you so much, Dr. Adel, for this nice case, and I really like the way how you handle the case and the nice outcome this patient had. And so now, for the sake of time, we will move for the presentation of Dr. Ahmed Al-Barqi. Then we'll come back with all the discussion and all the questions. I have plenty of questions for you, Dr. Adel. So thank you so much, and we'll come back to.
So we will keep
so
the
now,
question
Dr.
at the end, right?
Yes, so we'll keep the question at the end. So we'll have like a very rich discussion between all of us to answer the questions by the audience and our question.
I'll stick around.
So next speaker. So next speaker is Dr. Ahmed Al-Barqi. He's my colleague. He work at the same place where I work. So he's from he's a retinal surgeon, Sheikh Khalifa Medical City here in Abu Dhabi, United Arab Emirates. And he's associated professor, University of Banha, Egypt. And he will present a very nice, mysterious case, OR mystery. The floor is yours, Dr. Ahmed.
Thank you, Noura. Thank you so much for your introduction, and it's really a pleasure for me to be here with you today with my colleagues from Saudi Arabia and from Canada. So I'm going to share with you one case. I hope it will be interesting. Can you move the? I cannot move the slides, please. No, just not that one. Okay. Let's see here. Yes. So just to give you an idea about the case, the history of this case, we can fast forward this introduction, or we can just go direct for the case. Yes. This is a patient, 75 years old, female patient, no history of diabetes or hypertension. And we can stop the video here, please. Decreased visual acuity for 8 months ago. And let me tell you something here. The history, while taking the history of the patient, it was not clear enough. There is no history of trauma. And this patient was those kind of patient that's very silent. They're not complaining. And she discovered you cannot see in this eye when the other eye was getting some infection or something. And when discussing with her daughter, So we take a long history and we decide that it's not acute onset of drop of vision. It's a long time ago in the eye. And as I told you, you have a very dense cataract also. That's why it might be mask the problem in the retina. And when we do B-scan for the retina, we found that they have a dense vitreous hemorrhage. So I just want to show you here the B-scan of this patient. You can see here. It's not, sorry, it's not. Are you seeing my slide or no? Noura?
I'm seeing the video.
Now we can see the B-scan, right?
Yes.
The B-scan. Can you pause the B-scan, please, boss here? Because I want to ask you. This is just one. The reason for the A-scan overlay is not there because when I copy the image from the B-scan machine, does not show the A-scan. But let me tell you that the A-scan, the echogenicity of this layer was high, the layer of front optic disc. So I just want to ask Noura and Ali, what do you think about this? Is retinal detachment or no retinal detachment in this case?
Given that you're presenting it, I think it's a retinal detachment.
And Noura?
So you said the echogenicity was high?
You can say it's not very close to the retinal. You cannot. It's very high. It's very something. It's not. If you look at this frame also.
Was there posterior hyaloidal detachment or?
No. You can see here. If you look at the B scan, there is a vitreous hemorrhage very clear in the.
Yeah.
But I'm talking about this thick layer at the optic.
Yeah, it's very thick. Yeah, it's very thick. It's even thicker than a retina. It looks like some tractional band or tractional thing. So it's like a separate thing.
So so when I decide to operate on this eye, I put in my back mind that there might be a retinal detachment there. So it's not only vitreous hemorrhage. So let's see the case. First of all, the cataract was very dense, so you don't want to waste your time with the cataract. Usually in this case, I use what we call back shop technique for this dense cataract. But let's go to the retina because there's nothing. We do the cataract and eventually remove and put the implant in the IOL and the bag, and then we suture. Usually I like to suture the 2.2, even 2.2 for the to control the intraocular pressure during surgery. And then this is now we go to the inside the eye. You can see here vitreous hemorrhage, dense vitreous hemorrhage, as you see here. So I will try, as you usually in this kind of videos, try with cool vitrectomy in the middle, and then usually you go peripherally, trying to look what's happening there, because if you make it like a small hole or something, and this is retina behind, it will be peripheral. What I want to highlight here, that you can see the multiple layer. You can see here, and then when you make a hole, there is some blood coming from behind, a lot of blood coming, so you have to aspirate it. And then, if you look here, you will find that it's still aspirating the blood, a lot of blood coming. There is a hole here. I make it a small hole. I think this is still inside the vitreous. So I go with this hole peripherally as much as I can and aspirate again. You can see here there is shower of blood clots coming. I will later on it will be more. So I'm trying to look here. If you pause the video, I can, I try to look here during this opening, trying to see any details of the retina. Any blood vessel or something like that. At that point, I didn't manage to see. There is a lot of blood behind even. So I continue trying to go there peripherally, and you can see here. That's what I want to show you. There is something like two layers. One layer is gelatinous one, which is definitely the vitreous. And if you can see behind, there is some layer, thick layer, like rigid one, like a leaf, dried leaf. So I continue vitrectomy on the vitreous. I'm still worrying, but once it's flipped down with me now, I'm trying to remove this layer or separate this layer from the layer behind. And this one. If you stop here while doing this, I'm still trying here to separate this layer. I'm so cautious about not to go. I'm in the correct plane. I want to show you something. Yeah, you can see here the two layers. But if you stop here, please. When you flip this layer upside down, I can see there is a lot of blood clots here. So definitely this is not the retina for me. Because this structure, we cannot see it behind the retina. So something is strange, but it's not the retina. So I make, okay, this is not the retina. It's just a thick vitreous hemorrhage. Let's go and continue the surgery. You can see here in the back, this is not, looks like retina. And here I start to see some vessels. It's not clear in the video, but intraoperative, you can see some shadows of some blood vessels there. So I decide to go vitrectomy. This is a case of vitreous hemorrhage, atypical with layer like vitreous chisis there, and also there is behind, we will see later on, there is a very dense and very giant, let's say giant blood clot during the so I'm keeping the vitrectomy briefly, as you see, trying to separate this layer from the behind. And then let me go forward a little bit, just for the sake of time. I want to show here this how there is multi-layer in this vitreous hemorrhage. It's not one layer. And here again, this showers of blood clots coming every now and then, and it's remind you as if you are hitting bees' nests, and the bees are attacking you inside the eye. So that's the feeling that. And if you can see also some of this blood clots, shower of these clots is stick on the back of the posterior capsule. Anyway, so just for the sake of time, I want to show you how can we deal with this giant break. First of all, you have to remove the vitreous if you manage to deal only with the blood clot, because it will be expected to be very adherent to the retina. So you don't want any counter attraction there. So first you have to remove this layer of vitreous away, and then deal with this blood clots at a later stage. Still blood clot showers coming every now and then, and you have to be patient and to aspirate as much as you can. And there is, this is the one I'll show you here. This is the vitreous. You can see here I'm cutting, and this is the layer I told you about. It's like leaf-like. I don't know, this is because of the chronicity of the blood. First time to see like this. Again, shower coming. Be patient, aspirate. So now we have three layers now. One of the vitreous, the second one which is a leaf-like structure, also vitreous, and behind that we have the giant clot. So what to do in this case, I remove all this blood now. You can see, this is very obvious. You can see it's like a thick layer of rigid layer also. Now we are dealing with this huge giant clot. The basic thing here, you cannot remove it in one time or in block. You have to desegment it. So what you can see now, I'm trying to segment it into pieces to make it smaller, to leave it, to remove it piece by piece or segment by segment to avoid any traction, because I cannot see what's behind. So you can see here I'm using the vitrectomy probe as a vertical scissor, trying to segment this giant clot piece by piece, as you can see here. Again, cutting here, you can see I'm trying to separate it segment by segment. And you have to be very patient also in this case. Don't rush, take your time, because you don't really I'm expecting there is some point of traction between the giant blood clot and the retina. Till now there is no traction here until now. So I'm keep the segmentation of this blood clot, take it, eating it, and now I hope that you can see behind there is a subretinal whitish membrane there. It will be more now. You can see it here. Again, there is the last piece. Trying to shave it or cut it or desegment it peripherally, and then trying to separate it slowly, gently, and then you cut it, and it was adherent to the retina. And after I remove it, I found, as was expected, there is some retinal. You will see it here. After I remove the last piece, there is a retinal hole here, big retinal tear, and because the retina overlying was so atrophic. And this is not the end of the story. After I remove this, I still find, as you can see here, there's some blood at the edge of the tear. But you can see here still the whole retina, or most of the retinal surface, is still covered with this blood shower clot. So I have to remove it with the back flush. And you can see here I'm using active suction because it was thick. So I active suction, just hold it, take it away from the retina, as you can see here, gently for sure. And as I'm going to show you later, in a second, see how thick was this layer. just I'm trying to very gently to remove from the surface of the retina. Most of the retina surface, as you can see here, is very covered with blood. You can see I am feeding it with the endolite because the active aspiration only cannot remove this clot through the backflash needle. Because I'm trying to, you can see here, it cannot go even with active extraction. I have to feed it inside the eye. So I finish all this. It takes me time for sure to remove all this blood on the surface of the retina. There is some lipids, and it is common. You can see in the chronic vitreous hemorrhage. We can move forward a little bit because I want to show you what the end. So I go to the other side, still using the same, trying to remove all this blood which covered the retina. It takes a little time. And now completing the vitrectomy periphery, and then go to this subretinal membrane. It's already there a tear, so there is no harm to remove it. But look at this membrane. It was very big and fibrosed. It's taken me a long time also. You cannot imagine how tough was this membrane to remove inside the eye using the vitrectomy cutter. It was very difficult to remove. It was very thick and fiber. But at the end, we managed to remove all this membrane. And look at the location of the membrane because it will be point of discussion after the end of this video. Now I've shifted to air fluid exchange, and I want to show you some trick here. If you have, I will hold the video, please. I don't know if the agent's seeing it's hold or not. If you want to unfold a folded tear edge like this, it's not really, I mean, extremely folded. You can just, tilt the eye down while making the air fluid exchange and put your backflash needle distal or peripheral to the edge of the tear, and the airflow itself will going to flatten this folded tear, or folded edge, sorry. So at the end of the surgery, we remove all the blood, air fluid exchange, silicone oil, endolaser for sure about this tear here, and do for laser 360 degree, and then we put silicone oil because the tear was a little bit posterior, just superior to the arcades. And that's it. I think that's the end. We put silicone oil, sorry, and the vision improved tremendously post-operatively. This silicone oil, as I told you, this was 23, and this is the end of my video. So if you go to discussion, I need to ask my colleagues. First of all, to Noura, what do you think about this membrane?
Well,
I think.
Go ahead, Dr. Anwar.
Hello?
It's okay. Can you hear us, Dr. Ahmed?
Hello?
Dr. Ahmed?
I'm not sure if he hears us. Dr. Ahmed?
I cannot hear you.
I don't think.
Hello?
I think he doesn't hear us. Dr. Ahmed? We can hear you, Dr. Ahmed.
Can you hear me?
Yes.
Hello?
No, he can't hear us.
There is something wrong. Hello?
We
Dr.
can
Noura?
hear you, Dr. Ahmed. Yes.
Can you hear me?
Yes, we can hear you.
I cannot hear you, Dr. Adel.
I think you need to turn on your mic, your speakers.
Hello?
Yes,
Yeah, I can hear you. Sorry. Now, yeah, sorry. It's my. Sorry. Yeah, okay. So I didn't hear you. Sorry for that. I didn't hear your answer. What do you think about this membrane? What could be the reason for this one?
I think it's, I have seen so many cases of AMD with very dense chronic recurrent vitreous hemorrhage, and I think there is a big difference between AMD or CNV-induced vitreous hemorrhage and PDR vitreous hemorrhage. So usually they come like very dirty vitreous with multi-layers of recurrent vitreous hemorrhage, and you can see, according to the chronicity of the vitreous hemorrhage, you would see those layers of like very thick bands with
no, I'm talking about the membrane itself, because the location of this membrane, it's not typical usually what we have seen in choroidal neovascular membrane. It's almost, if you look at the video, it was outside the arcade or at the edge of the arcade. It's not not the normal location of the choroidal neovascular membrane, and the patient is healthy and the other eye is perfectly normal.
So there's an entity that's similar to choroidal neovascular membrane, where you actually have somewhat posterior, which does not have a very posterior choroidal vascular membrane, and it does tend to present with a lot of vitreous hemorrhage.
Okay.
Yeah, peripheral exudative chorioretinopathy, I think.
Yes, yes.
Yes.
So,
Okay.
so
Yes.
this tends to happen, but the way you showed the blood, how it behaves, like it's a very like basically like it's a piece of like I don't know. So it does not cut. It's not cut with the cutter. You're using a 23 gauge cutter and it's not working. I do want to know what settings do you typically use? Are you the kind of surgeon that likes 10,000 cutting starting?
Yeah, for sure. Yes. I use the maximum cut in my hand for sure. Yes, but and the vacuum, it depends. You know, in those cases, I don't have a fixed vacuum, but usually most of the cases with this closed system, I think minimum I use 500 for the 23 gauge, and I reach a maximum vacuum like 650 in 27 and 25. And it's very safe. I didn't find any problem with this small gauge technique of vitrectomy.
Yeah, if it was a smaller gauge, I would think that this is typical. But yeah, I agree. It's a very hard blood clot that does not go away. Yeah, it's not very usual.
So if you allow me just to discuss with you this, because I know that you and Noura, you have fellowship in Canada, right? A lot of AMD rather than in our region. So in your real life of the vitreous hemorrhage in wet AMD, you know, in the trial they said the incidence is like 12%, but how frequent you see it in your practice? The vitreous hemorrhage as a presentation of, if we consider this a case of choroidal neovascular membrane. So what's the incidence of vitreous hemorrhage? Do you see frequently or very rare, or I mean one in Canada, for example?
I have seen it like maybe 3 to 5%, and it was mainly in either neglected AMD with huge submacular hemorrhage, or in this peripheral exudative chorioretinopathy where they have peripheral CNV, but it's not a very big number of patients. Usually older patients, like above 80. Okay.
So Noura, you mentioned something about the subtypes of CNV. There is sometimes that, do you think that some types of CNV that really matter, that maybe for a RAB lesion can bleed more than the type 1 or type 2, leading to vitreous hemorrhage, or it does not matter whether the type of the CNV can cause this kind of hemorrhage, vitreous hemorrhage I'm talking about? Because I see some series of cases, it's a very small series, it's more common with RAB, but I don't know, what's your experience, you and
I'll tell you myself, I've faced one case in my career, which is a short one.
Yes.
The blood was very dense. It behaves somewhat similarly, and it was a little bit posterior. I could see that we could not really get a very good fluorescein angiography in that case, particularly. Wouldn't be able to tell you, but from what I read, it's mostly RAP, as you mentioned.
Yeah. Okay. So. One before the last one, the possible reason, what could be the reason that patients can present with vitreous hemorrhage in wet AMD? It's maybe it's overlooking or underdiagnosed, or maybe delayed treatment, or maybe other combined pathologies. You need to investigate more just to avoid this, or it's just a natural course differ from one patient to another. Yeah, I'm just brainstorming. I'm getting your opinions. Yeah.
I think delayed treatment with those patients. So the blood will go to the vitreous, right? This is what
delayed,
I believe.
Or maybe under treatment, right? I think so.
One of the reasons. Or under treatment, exactly. And I have seen it as well on those patients with polypoidal chorioretinopathy.
Polypoidal, yeah.
They tend to have, yes, exactly. So they tend to have this very aggressive kind of vitreous.
Yeah, okay.
What do you think, Dr. Adel?
Dr. Adel, if you have any other comments.
The part of it is that because of the presentation, I mean, those patients don't typically present with with a typical coronal muscular membrane posteriorly, where the vision starts dropping because of the fluid that they develop, and it's only that they present having a complication of vitreous hemorrhage. So that's why we tend to see them in this stage. I think having a very good screening program for those who are non-diabetics, like this lady, would help. But unfortunately, because of our, and I assume this is the same in the UAE, our diabetic retinopathy situation, we are all focused on diabetic retinopathy. Maybe those cases don't typically get the dilated frontal exam that they should take.
Yes. So the last point here, I want to ask you also, take your opinion about how, if you have a case of how to prevent, how to avoid this complication if you have a patient with HEMORRHAGE. Do you have a special treatment protocol to follow, or any other way of diagnosis, diagnostic tools to help you to avoid this patient? Even the general condition of the patient doesn't matter if he's on anticoagulant or something. So what is your treatment protocol with AMD just to avoid this complication?
Typically, those cases are treated by laser because they follow the MPS protocol, where you actually have a macular photocoagulation study, and you typically laser those cases, and they do well typically. But the problem is they don't present to you. That's why they only come when they have the complication.
Noura, other thoughts?
I think for treatment protocol, I would recommend, for example,
I mean to avoid complication like vitreous hemorrhage or submacular hemorrhage, you know, not to reach this stage.
Yeah. Exactly. If you decide to do treat and extend, be very cautious about the interval, how long you can extend your patient, especially if the patient is monophthalmic patient. I wouldn't be very safe to stop the injection at all, but I would consider like extending them to 12 weeks, for example. So I will be sure that this patient will come and they will secure them with an injection to protect their eyes from having this very bad extensive complication.
So let's say if the patient is a single-eye patient and he lost the other eye, for example, from the complication of wet AMD, so do you still treat him and treat and extend, or you will be more aggressive? This is both of you, you and Adil also. I mean, or you have your regimen. If you're single-eyed, does not matter. You're still treating and extend those patients.
Myself, I would laser.
Yes, you laser. You still laser. I'm totally against laser, but anyway.
But Dr. Abdi, would you laser even macular CNV, for example, macular CNV like AMD? You mean outside the macula, right?
Outside the macula, I'm talking about.
Yeah, for sure.
Yeah. Outside the macula, yes, I think would laser it as well.
About this condition specifically, but yeah, definitely when you have an eye patient who has a typical AMD related choroidal neovascular membrane, I would typically keep him on a fixed regimen. I won't even have the guts to just
I will do the same if the patient is single-eyed and the other eye lost already from complication with scar. Definitely I'll be more aggressive, so I will keep him and fix it dosing at least in the first year. And what I'm doing extra, that I told you, one of the reasons that we miss or undertreat the patient, that could be another pathology. So if it is not clear, I can do for him more investigation. Like if it's not responding well, maybe I do some ICG or OCTA just to do, if there is any kind of polypoidal lesion, I can combine it with the BTD, because there is some results show that if you combine BTD with anti-VEGF together in BCV cases, you might respond well. So I mean, we are on the same pathway regarding this treatment. So the best way is to do not undertreat and treat aggressive if needed. And patient education is a very important point to stick to the clinic visits and to avoid such kind of complication. So thank you so much for your attendance. So now I stop sharing my screen now.
Thank you
Any
so much,
question, or
Dr.
should
Ahmed.
we
Very
stay at the
nice.
end, Noura, or we will go for the...
I think because we are running late on time, I think it's better to leave the discussion and then we need to finish our presentations. What do you think?
Okay. Okay, because we have
Yeah.
still we have a lot of, but we can manage
Yeah.
to answer this old question at the end.
Yeah, exactly. So leave it to the end and
Okay, so I will mute myself now, and the floor is yours, Dr. Noura. Oh, so we need to introduce Noura first. Sorry, I have to introduce Noura. Noura is my colleague in Sheikh Khalifa Medical City. He's a retinal surgeon in Sheikh Khalifa Medical City. She's did her fellowship in Canada, 1 year in US, then right, Noura, and then the other 3 years in
yes,
Canada.
exactly.
Yeah, so
Exactly.
she's very elegant surgeon, I have to say, because I know Noura since she was our resident, and now she's soon she will become consultant. Maybe you are already consultant now, Noura. So we are really eager to hear what you're going to tell us. So the floor is yours, Noura.
Thank you, Dr. Ahmed, for this nice introduction. So my presentation is about retina, how I wonder where you are. So I try to make it quick, and my case is a 70-year-old female who presented with us after, so the history, she had a PKB done somewhere else, and the patient, she poked her eye. Then she had a corneal dehiscence, and she needed a primary repair to suture her cornea. And when almost like couple of days less than 1 week post-op, and they noticed there is kissing choroids, and they referred her to us. So past ocular history, she had the pars plana vitrectomy with the posterior capsular ocular lens for steroidylosis, like 1.5 years ago, and this is her left eye, and the right eye, she has very bad diabetic macular changes with very atrophic macular hole. And this eye was her best eye, and she used to correct to 2200 in this eye, unfortunately. So the patient came with a very severe eye pain, even with all potent painkillers. She used to take very strong painkiller like regularly, but still she has this severe ocular pain. Her visual acuity was query perception of light, so the patient was not sure. Sometimes she's seeing the light, sometimes she's not seeing it. And the pressure was 9, and the SIDL test was negative. So this is her B scan. And why it's very important to do B scan in those kind of patients? Because post-op primary repair, cornea, sometimes it's not very clear, so you need to make sure how is the status in the back of the eye. Without doing a B scan and you cannot see inside the eye, it will be very hard to tell about the status of the back of the eye. So this is the B scan of this eye, and you can see there is a huge choroidal detachment, mainly choroidal effusions, with the touch on the retina. So and it's very important as well to do the B scan if you are going to take those patients to the OR, because you need to plan where are you going to do your drainage, sclerotomy of those cases. So you need to go at the highest point where is the choroid is detached. So I have a question for Dr. Ahmed and Dr. Adil. And for example, if this choroid is not touching, and if this choroidal is not touching and the retina is not touched, and the patient has severe ocular pain, will you take this patient to the OR to drain the choroids or not? And how long would you wait?
So I would, especially given that this is a patient who is hypotenuse. Although you mentioned that there is a lot of there is no the negative SIDL test. I wouldn't be very eager to go and interfere as soon. I would still give it time for it to occupy. Maybe push it as much as I can to the 7-10 days duration that I typically wait for draining a subretinal, submacular, or suprachoroidal hemorrhage. This is how I would approach it.
Yes, Dr. Ahmed, any comment?
Yeah, I think yes. I think it's if there is not kissing choroid, I mean not touching, and the retina is attached, and there is, as Adil said, there is no leakage or negative sedal test. So I think I can wait a little bit, and for the pain, we can give the patient painkiller and keep follow-up. But for sure, I'll keep eye on this patient. I will not ask her to go home. I will admit her, and I will keep it on my eye day by day examination just to check.
Exactly. So thank you. And so for the management of choroidal detachment, you can. So I'm not going to discuss the risk factor and the causes of the choroidal detachment. So I'll go immediately for the management. So there is a conservative management, which is only just watching the patient and give them some eye drops like steroid eye drops and cycloplegic and just follow those patients regularly. And if usually they will depend on the size of the choroidal detachment, but usually they will resolve by their self. And the surgical management, it's either you do cut down, a scleral cut down to drain the subchoroidal fluid, or you do transconjunctival by Broca's techniques. So this is an intraoperative video of my case. You can, so I will present my video, discuss few tricks and tips on this video. And first of all, before I run my video, you can see, especially for vitreoretinal surgeon, and it's very hard to put your infusion line in the pars plana. That's why your infusion line, you should always start with the infusion line in the anterior chamber. Because you need to, before you drain, you need to make sure you have access to the eye to increase the intraocular pressure, because this will help to drain all the subchoroidal fluid. So we start with putting the infusion line. This one's 25 gauge vitrectomy, and we put the infusion line in the anterior chamber. And now I will run the video. So the infusion line in the anterior chamber, secure your infusion line. You can see the red reflex is gone. There is no red reflex. Do your conjunctival cut down, and you drain this. You can see the subchoroidal fluid, and you drain the subchoroidal fluid. The distance, can you stop the video, please? The distance, it's different. That's why you have to know where is the highest point, and the location is different. Usually, the choroid is the choroidal detachment is highest. Fortunately for us, because it's easy access in the temporal infratemporal space. And usually, the distance it can vary from. So it should be more from 6 to 8 millimeters from the limbus. The more anterior you go, you won't go in the choroidal space. The more posterior you go, you might go into the retina. So you have to be very careful in the way you drain the subchoroidal space. So when you drain, pump your pressure high, and the fluid will come back by itself. Then you notice here, can you stop the video? When I introduce my trocar, you have to go, you cannot bevel your trocar here. You cannot do the 2 or 3 steps technique that we used to do it in regular vitrectomy cases. You need to go immediately sharp inside the eye. Unfortunately, this patient, she's pseudophakic, so 3.5 millimeter from the limbus, and you go inside the eye. The other thing is, you go in, then I will stop, sorry. So you go in, and always check you are at the right space. So I went in with my endolight. I made sure that I'm in the right space. I'm not in this under the subretinal or subchoroidal space. And when you go in, you have to go in parallel and flat to the iris to make sure you are away from the retina. So this is. I put my endolight, and you can see I'm checking my visual axis. This patient, she had her recent corneal transplant repaired. Sorry. So this patient, she has her recent corneal transplant repair, and I noticed the cornea is not clear, so I had to remove the epithelium. So don't be very hesitant to do keratectomy in those cases, because having a poor view in those cases will make your life as a nightmare. So you have to know how to do a very nice keratectomy, so you won't compromise the cornea later on. And as well in those cases, you won't cut down your sutures, because you don't want to cut those nylon sutures, because you will have to put them again. So you can notice here in my video, I'm removing the epithelium with the beaver blade, 57 blade. Remove the epithelium. Again, insert your other broker flat. And you can notice here, if you stop the video, please, this is the view. You have all of this dirty looking fibrous band anterior on the vitreous. So it's very important here to be patient, take your time. Usually, sometimes choroidal drainage will be very easy, and immediately you will notice the retina is flattened and the choroid is flattened. Sometimes it won't be the case, so just be patient, take your time, try to know your anatomy, where are you in the space of the eye. So I would recommend doing your peeling and removing those membranes and those fibrinous membranes slowly, starting from anterior to anterior posterior. So you can see here the anterior hyaloid is still present. The view is very terrible because of the corneal transplant and the epithelium, so you need to be very patient. So take your time, try to get the best view you can see, and here you can see I'm peeling. And for me, I don't like to go on core, so I will use my shave sitting here, because I need very stable cutting of those bands in a way that I would make sure that I'm removing layer by layer, and making sure that I'm not inducing any iatrogenic tears, especially with the choroidal detachment and retinal detachment. And you can see how already this eye started to form those bands and adhesions between the retina. Although knowing that the patient, she is already vitrectomized patient. Here, if you stop the video, I decided to go to change my instrument to forceps, and you can notice, if I repeat it, when I was introducing my instrument, there was some retinal dragging. That's why you have to be very careful while inducing your instruments. You have to always to remind yourself to be flat and parallel to the iris when you induce your instrument. So here I'm trying to peel all of those bands, and I want to know what's happening in this eye by slowly peeling all of those bands and doing with my endolight, I'm helping myself to push the retina away. And if you notice here, after I made sure the inferior temporal pars plana is clear, there is no retinal detachment, I decided to put my infusion line into the posterior segment. It's better to put your infusion line to the posterior segment, because you will have a better control of the intraocular pressure, and as well you will avoid any leak from this fresh corneal laceration repair. And after I introduce my always check your trocar, make sure that you are at the correct place, you are not in the subchoroidal or in the subretinal space. Then after I finished, and now fortunately we can see the optic nerve, and you can see there is a very big fibrous bands all over the retina with those intraretinal hemorrhages. And slowly try to peel them, remove them. And you can see I'm trying to remove those. I'm trying to remove and know what's happening. Is it a retina? Is it a remnant of the anterior hyaloid? Is it fibrous material that's starting to form to make adhesions? So while I'm doing this, I notice there's still some choroidal, can we stop the video here? I noticed there's some choroidal detachment, supratemporal, so I decided to drain it as well. Same technique. Fortunately, my infusion line in the back of the eye, I decided to drain the same technique, and I would make sure, is it a retinal adhesion that caused destruction, or it's the choroidal detachment. So drainage of the suprachoroidal fluid. And now I notice my corneal wound is open, so I decided to put another suture. You need to maintain always, your target in the surgery is to maintain the pressure of the eye to avoid any recurrent effusion, because in cases of post-glaucoma cases, if the pressure fluctuates tremendously intra-op, the choroidal effusion will immediately happen at the same moment. That's why you have to be very careful. If there is any leakage, you have to suture it and to maintain it immediately. And especially in this case, because it's a post-corneal transplant, always make sure that your cornea colleague is on board in case you will need to remove and to put prosthesis and to do a revision of her PKB. So after putting this corneal suture, I went back again to the eye. You have to be very patient. And you can notice I had an iatrogenic retinal tear. Unfortunately, I managed to put the retina in space. This is air fluid exchange. And so I left the eye in silicone oil, because this is a very sick patient. She would not be able to position at all. And as well, knowing the prognosis of this case, those patients tend to have very bad PVR due to those, already she's forming some sort of PVR. So you need to be very careful. This is her image before and after drainage and peeling all of those fibrous adhesions on the retina. And 1 month post-polar vision tube, still counting fingers, very close to the face. She is fortunately pain-free. So the patient concern in those cases is for you as a physician to help them to get out of this pain. It's very painful. She could not sleep, she could not eat, she was very depressed because of this pain, and she cannot pursue her normal social activity because of the severe pain that she had. Cornea, fortunately, was clear, and her corneal transplant survived all what had happened with repeated surgery and all of this intervention. And fortunately, the retina was flat under silicone oil. So what are the perils and tips and tricks I can provide you for drainage subchoroidal fluid is always you need to document the vision. This is first. Then you need to be very confident and familiar with your B-scan machine, because you need to know what's the highest point of the choroidal effusion. Then those eyes usually painful, so you need to be very generous with anesthesia. You want your patient to be very comfortable during the surgery. So you can decide doing it under general anesthesia, doing local anesthesia. In this case, I went under local anesthesia because she's very, she has multiple comorbidity, and it will be very hard to put her under GA from the anesthesia point of view. And the other thing is check and treat any signs of leak, because the main cause of choroidal effusion usually it's hypotonia. And the other important point what I mentioned in my video is AC infusion line. If you are not a vitreoretinal surgeon, still you can do a choroidal drainage by using AC maintainer, which usually our cornea and glaucoma colleague are using. And I forget the name of the instrument, but they have something that they can put in the AC. It's 23 gauge, and they can put it in the AC and connect it to an infusion line, and this will help you to control the intraocular pressure. Then you can drain your choroid. Whatever technique you can use and you are comfortable with, it's okay. For me, I can use both of them. But a gentle reminder, if you are using the trocar technique, is to be parallel with the sclera and not to point into the retina, so you will not cause any iatrogenic tear with after you drain your subchoroidal space. And as well, make sure you open your valve. So the newer trocar that we have, all of them, they are valve trocar. Whatever gauge you use, it's okay, but it's preferable to use the 23 gauge. And during insertion of the trocars, put your trocars parallel to the iris and go straight on, and always watch for retinal dragging, because you might induce peripheral retinal tears that you don't want to cause in those cases. And the other thing is, try your best to clear your view, and don't be hesitant to do keratectomy, and always ask your corneal colleague about the best technique to do keratectomy to avoid any corneal scarring later on, and to do the peeling and removal of this delicate technique. You always to start anterior posterior, take it layer per layer, be very patient and take your time. Use very low sitting and like shaving sitting, so you will make sure that you will not touch the retina, because the retina is close to your working space. The other thing is you have to suture all of your sclerotomy, because you don't want this eye to go into hypotonia and the post-op status to prevent any recurrent choroidal effusion. So always, even if you did not suture, you have to suture them anyway, because you are going straight on the eye. So always make sure to suture those sclerotomy. And the other thing is be ready to come back on those eye if needed. So you have to see those patients regularly, and always when you take the consent, make the patient aware this is one of the worst medical eye condition that can happen, and they need to be aware about how big is the issue in their eye. Not to frighten them, but to make their mindset as aware about how bad is the disease in their eyes. And always make sure to take a deep breath, especially in the intra-op, and relax, because being an anxious surgeon will make everything worse, and you might cause more harm instead of helping those patients. And this is my presentation. Thank you.
Okay, thank you, Dr. Noura, for your excellent case. It's very challenging, you know, the choroidal hemorrhage or choroidal effusion, one of the challenging cases we all know because of the hypotony. Because we have many questions, I think we should go for the audience, because we are here for them. We need to involve them more.
Right.
So, yeah, one quick question, Noura, I want you to comment. One of the mentioned technique or steps that after you flatten the retina a little bit and they still have choroidal detachments or effusion, some surgeons they prefer to do perfluorocarbon PFC to hold the choroidal vessels, choroidal fluid to go out from the drainage point you have done. Any comment about this technique?
I think, yeah, it's a technique that you can do, but you know, knowing the fact of PFC is sometimes it will be challenging in cases if there is adhesion, and it might go in the subretinal space.
Yeah, for sure. You have
so
to
it will be another nightmare.
No tear, yeah.
Yes.
Yeah, sure, definitely.
Exactly. It will be another nightmare to remove this PFC in the intraocular space. I don't mind to use it, but in this case, because of all of those adhesions, I was more thinking about more adhesions than the choroid what's causing the detachment. But yeah, it's a technique that you can use definitely, and you keep it in your drawer in case if needed.
Very good. Dr. Adil, any comment before we go to the question from the attendees?
Yes, thank you, Dr. Ahmed. I think that this is a very challenging, you demonstrated a very eloquent technique in dealing with this surgery. What I've noticed that you've used a smaller gauge vitrectomy in this procedure, and I think managing this case was very well with this kind of instrumentation, knowing that you're working in a very narrow space where you may need to bend your instrument, squeeze on them, and getting this result, I think is a very good thing, and it's a testament for a good surgeon and for good instruments in this kind of situation. I would say that choroidal in a patient who is vitrectomized is a very challenging situation, because you know that if you have, you might get this sticky, stuck, the retina stuck in both ways, and then you can't. There's nothing to prevent the retina sticking from together now that you don't have any vitreous, and this makes everything very difficult to deal with. I would want to add that there is this difficult balance, and you've tackled this and mentioned this very clearly, between going in too early and going in too late. Because you tend sometimes to wait, and then you go in, and it's sometimes that the choroid itself, especially in such sick patients, is very atrophic and maybe sometimes flaccid, and you end up trying to drain, but it's not the blood, it's just that the choroid itself has fixated into this condition where you actually cannot really get the fluid or make it settle down, even if you try to drain at the situation. I think also using the bimanual technique in this kind of situation can be of an added value, because you have a lot going on. The space you're moving is difficult. Sometimes you want to be you want a third hand, let's say, in this kind of situation. So definitely it would be of help. But again, it was a very nice surgery. I think this patient got the best management she could get.
So I think we could take some questions since you are here, Dr. Adil. There is a lot of questions actually for you. So best we need just quick answers as possible because of the sake of the time. There is one question from Dr. Muhammad Nasser. He said, why creating retinotomy and attempt to drain and aspirate the subretinal hemorrhage? In your case, Dr. Adil, do direct aspirate the subretinal blood?
Why not directly aspirate the subretinal blood?
Through retinotomy, yes.
I would say that generally the aim is not to create a break in any retina. So if you can create a small break that's self-sealing, would be the ideal situation, because you don't want to create PVR and go into this cycle.
Yeah, so its technique, its technique you are going to do has definitely pro and con. So you have to decide which one is what about also, let's ask you about, what about subretinal or subretinal injection of air together with the TPA? Do you try this, because it will displace the blood more beautifully than the only one?
It's a very useful technique. Sometimes you can do this cocktail of anti-VEGF, especially in those cases of that are related.
But this anti-VEGF have no rules, because it's not due to protein vascular membrane. Yeah, this is traumatic hemorrhage. Yeah. So another question, Doctor. Some surgeon advocate. Yeah.
Air in this case was not.
Can I add a comment?
Yeah, sure, Doctora.
It's an inferior.
Yeah, I have done.
Yeah, inferior.
Hello?
Yes, Doctora Noura, yes, go ahead.
Yeah, I have done plenty of those cases, and I noticed if you do ILM peeling, it will make it very easier to puncture the retina with your 41 gauge cannula. So if you notice that it's very hard to do a subretinal injection, I think doing ILM peeling at the same time will help you to make your blood. The other thing is injecting the TBA in very low rate, like 8, even 12, and seeing drops before you go inside the eye, seeing your fluid is dropping slowly inside the eye, and the air as well will guide you that you are in the subretinal space. But be very gentle, because macular is documented.
Yes.
Macular hole is a documented condition of cases.
So that's give me the next question from Dr. Ahmed Salam. He asking how far from the fovea you inject the TPA. Dr. Adil?
So you need to stay within the macula.
Okay.
I would say that I would go as far as I can, closer to the large trunks. But I would still stay within the macula.
Okay. Also, there is a good chance, because I think most, not all the vitreoretinal surgeon. So can you describe for us the technique exactly? How do you inject fluid under the or TB under the sub? If you want to use retinal detachment using 40 gauge or 38 gauge, what is the parameter? Are you using a machine or using your hand? What exactly? How do you do it?
If you want me to share the video again, but I'll just say it quickly. So basically the idea is that you connect the fluid you have into the VFC system that is used for injecting silicone oil, and then you connect the tip with a smaller gauge self-sealing cannula. You go injecting into the vitreous space, and then using the jet of the fluid that's coming, you penetrate directly the retina.
How much the power you are using?
So I would stay in the range of 20.
Okay, very slow. I mean, very slow as you can. Okay, very good. So another question, Doctor, also from Dr. Mariam. Some surgeons advocate the use of subretinal vision blue instead of fluorescein, as you show in your case. Adela. Any thoughts?
Well, these are all non-FDA approved medication for this use, but basically it's. There has been reports of toxicity with subretinal
vision blue. Yeah, sure.
Yeah, exactly.
Okay. I think Doctor.
I think there is a question for you, Dr. Ahmed.
Yeah, but let's finish with Dr. Adel first because he's here. So the rule of using fluorescein with stab inject, Dr. Adel. What is the rule of using fluorescein with stab inject?
I'm not familiar with this technique. I don't know.
Okay. I think this is the most of the question now for Dr. Adel, I believe. Thank you so much.
Yeah,
we can go now for some question for me, I believe.
Yes. So for you, I think Dr. Ahmed, they ask, would you recommend on this scan you gave, as it seems to me?
Yeah, we already discussed this during the video.
Yeah.
It was high echogenicity, so it gives you the impression that because this is the chronicity of the blood, so it's multi-layered, as you see in the video when you go inside the eye. So it's a multi-layered one, so it gives you the impression that there is some layer. I think this layer was shown in the B-scan, what the one I showed in the video that's like leaf-like. This was the layer, and behind this thick layer behind was the blood clot. And in front of this is the, I think now we understand more the B-scan when you go inside the eye.
Exactly. Another question for you, I think it might be a macroaneurysm.
Yeah, it could be for sure, but the issue here, it's the patient is not hypertensive, and it's you know, in microaneurysm you cannot find this thick subretinal membrane. It's like membrane exactly. It's not like a bleeding or fibrosed blood or clotted blood. It was a membrane there, but one of the diffuse diagnosis definitely yes. But if you look at the history, there is no hypertension or other risk factors. So I don't think so. With the best thing to send this for lab or histopathology to check exactly, but we cannot do that because we have to remove it. So this is the only way to know what's the exact of this. Yeah. So another question, I think. Something asking about electrophysiology before doing this case from iron toxicity. We don't have any history of foreign body, so we don't afraid of this. And patient has Dr. Adel, still one comment for you also about laser for CNV. So you elaborated, you do it for the parafoveal or outside the fovea, still doing laser for that. So
no,
this is the only indication.
Outside the macula. I'm talking about outside the macula.
Dark arcades. Outside the arcades. He means the peripheral kind of CNV.
Okay.
No, I'm talking about this.
Yeah.
CNV, AMD.
I think there is a question from Dr. Adel as well. What was the source of vitreous hemorrhage in your case?
Yeah.
So definitely the patient had some sort of a perforation there. I assume that this is something that happens around the ciliary body maybe, and although this is not typical in this case, but again, the injection was done by someone who was not very well trained in giving a peribulbar injection. So I think it was something.
So how did they notice? How did they notice? Because when we get the injection, usually the vision will go down, right? Because of the effect of the anesthesia around the optic nerve. How did the surgeon notice, and how did they make the diagnosis intra-op and they send the patient immediately to you?
The patient felt severe pain at the time. That's out of.
I see. Yeah, because they touched the sclera.
Familiar. Yeah.
Okay.
Yeah, it was a very traumatic experience, unfortunately, for her.
Nice. So there was last two questions, I think, but it's not there now, but I memorized it. I don't know why this appeared. They were asking about Dr. Durrani. One question was using of nebafenac in COMMOTIO retinae. So for me, I don't think it's have any rule. There is no study about this. Any comment from Noura or?
Same for me.
The same.
I don't think there is a rule.
Another question also was about the foreign body. If it is impacted on the retinal surface and you wanted to remove it, you are expecting to get a choroidal hemorrhage or from the choroids. So how do you control this during surgery? So I believe that I will leave it. For me, you know, before doing that, you just had to increase the pressure of the eye, do endolaser or diathermy around the side of the foreign body, and you remove it. And if you find another morbid, you can do diathermy. What I want to add here, that if you have a posterior perforation and you can see the sclera, one of the tips here is to diathermize. Be generous in diathermy at this age, because it will prevent later on the risk or the incidence of BVR. So first of all, you have to increase the pressure, do laser or diathermy, which I prefer diathermy better to control the bleeding from the choroid, and then diathermize all the edge of this area, clean all this, leave bare sclera, and make good diathermy to prevent the post-operative PVR, which is very common in trauma and foreign body for sure.
I think there's a very tricky balance there between having an impacted scleral foreign body where you're actually going and removing it. You'll end up having a posterior perforation that you will never be able to properly manage intraoperatively, and then the smaller kind of foreign bodies that you can remove and deal with in a safe way. So it's always every trauma is a different story.
Yeah.
Exactly.
Okay, Noura.
Any other comment or? It was a very nice webinar.
I think we exceed the time.
Yeah, we are like the 38 minutes behind.
But I'm happy we answered all the questions from the attendees. I'm happy for that.
Exactly. Very interactive, very nice webinar. Thank you. I enjoyed it, and I really like the flow and the sort of cases that you have presented. And thank you so much for being able to make it tonight. And I know it's end of Ramadan and everybody is busy doing their religious activity during this time of the month. And thank you so much. I really enjoyed it, and hopefully we will see you again in other webinars. Thank you.
Thank you, Noura.
And
thank you, Adel, and you, Novars, and the ECO, ISU. Thanks a lot. And for the attendees who attend with us, and we hope to see you soon. Stay safe. And I cannot say stay home because we are doctors, so we cannot stay home. This is for non-doctors.
Stay home as much as you can.
Yeah.
Exactly.
Have a good night. Bye.
Thank you. Good night. Bye-bye.
Thank you.